Hello again. I'm here to talk about retinal detachments. I have no financial disclosures to make. And so, in our brief talk on retinal detachments, we're going to go over the ramifications of having this condition. We're going to discuss the important role of the optometrist. We'll go over how this affects the patient's life, and we'll go over the different treatments we have available for this condition, including vitrectomy. What is a retinal detachment? A retinal detachment is a separation of the neurosensory retina from the underlying retinal pigment epithelium, the RPE. This is an urgent condition and it is life-altering. It occurs in about 1 in 10,000 per year, and the risk factors for it are myopia, trauma, prior intraocular surgery, and the prevalence increases with age. Once we have a retinal break, fluid enters it, and if there's vitreoretinal traction, this makes the condition progress. There are many types of retinal detachments: rhegmatogenous, tractional, exudative. Rhegmatogenous is what we most commonly see in practice. Patients experience floaters, flashes, and loss of peripheral vision. These are the classic warning signs that prompt urgent evaluation. There can be loss of visual field, loss of visual acuity. This will make reading and driving difficult, if not impossible. This can lead to a rapid loss of independence. The inability to work can lead to financial strain. This is a true life disruptor. Our patients are filled with anxiety and fear and are at risk for depression and loss of professional identity. The significance of this life disruption cannot be overemphasized. Our patients are filled with this fear of blindness, and they are uncertain about the future. Again, here, empathy is the key. We should acknowledge their distress, and of course, we should provide reassurance without underplaying the severity of their condition. The optometrist is the health professional usually first on the scene with this condition. It is important to recognize it early. An urgent referral often leads to better outcomes. With sensitivity, we should explain that this condition to our patients, set realistic expectations, and again, emphasize that they have an urgent condition. The diagnosis is made by examination, and imaging can be used, especially in the setting of a media opacity. The different treatments include laser, cryo, pneumatic retinopexy, and of course, the definitive treatment, vitrectomy. We'll go over some cases. Here we have a 48-year-old female who presented late in the afternoon to her optometrist with a sudden onset massive floaters. We saw her later that evening, and we saw that she had a tear at the edge of lattice. We treated her, and yes, she was out of network, but that's okay. Her optometrist likely saved her from a retinal detachment with early referral. Here we have a 68-year-old gentleman who was working at Costco when a heavy cardboard box struck his left eye. He immediately noticed the onset of floaters and came to our office, and here you can see he has a large tear and fluid is already entering. We went over the therapeutic options available to him, and he elected to proceed with laser demarcation with some supplemental cryo to reach those areas that were obscured by that mild vitreous hemorrhage. Here he is right after the treatment. And a month out, his visual acuity is improved to 20/60, and he is eager to return to work. Here we have a case of a 67-year-old female who presents with a shadow. There's a single tear there, and it's a bullous retinal detachment. She elected to have pneumatic retinopexy. And so we treated the tear with cryo, injected a gas bubble, had her position slightly tilted, and her visual acuity improved to 20/20. And here she is, still at 20/20, 5 years later, now a vibrant 72-year-old. Of course, the definitive procedure is vitrectomy, because this removes the vitreous, relieves the traction, and allows for retinal reattachment. It has a very high success rate, 90–95%. And of course, the visual recovery depends on whether or not the macula was on or off. And so earlier referral is very helpful. With the restoration of the anatomy, there is a chance that we can improve the vision and restore function. Here we have a case of a 55-year-old gentleman who works in the Stanford operating room. He presented with a macula-off retinal detachment. We performed a vitrectomy, scleral buckle, gas, and laser. As the gas receded, we saw that there was some shallow fluid building up, and you can see there's a little bit of PVR setting in. We returned to the OR, peeled membranes, and flattened the retina under oil. And here he is months later, and his visual acuity is 20/60, and he too is eager to return to work. The purpose of these treatments, of course, is to improve the vision and restore that visual field. Ideally, we can return these folks back to work and get back their quality of life. Now, these patients trust their optometrists even after these procedures, or especially after these procedures. And often, they will call you with anything that comes up. In fact, this past week, one such call took place, and thankfully that patient is doing well. In summary, retinal detachments are urgent and life-altering. Optometrists are the health professionals usually first on scene. With empathy, we can guide our patients through this challenging and difficult ordeal, thereby allowing us to apply our clinical skills, employ the different treatment modalities, reattach that retina, restore the vision, get them back to work, and continue living productive lives.